Dr. Goodman on the HemOnc Pulse. Aaron, thank you for coming on the HemOnc Pulse. You know, the HemOnc Pulse is the podcast that allows you to keep your fingers on the pulse of hematology. And you are one of the most amazing hematologists and social media provocateur. But you're coming in to educate us a little bit on Castleman's disease. Although I want to have you one day so we could yell at each other about minimal residual disease, but you chose Castleman's disease today. So I'm going to actually let you off the hook on MRD, and you're going to come back soon to talk about MRD. So a little bit about you. Who are you? Who is Papa Hem?
Well, first, it's great to be on the Pulse. It's my first time on. And if you want to just talk about eradicating MRD with selinexor, I'm happy to discuss an hour.
Not with selinexor.
I can go forever on that. So
I know you can.
Selinexor and a little talquetamab at the end. So I'm an associate professor at the University of California, San Diego. Live right by the beach, and I specialize in bone marrow transplant, leukemias, lymphomas. I consider myself a general advanced malignant hematologist. So I treat all malignant hematology from diagnosis to hopefully cure. If they need cell therapy, transplant, I hook them up with that. And I run the bone marrow transplant fellowship and do a lot of teaching. It's great to be here.
So we wanted to discuss today Castleman's disease because it's not really a very common disease, but certainly it's a disease that we need to recognize because there may be some treatment implication, and also you don't want to mix it with a different diagnosis. Is there a way to at least tell us a little bit more about, can you introduce us to Castleman's disease?
Yeah, you are, to any fellow or really any practitioner listening, if you listen to this 15 minutes or whatever we're going to talk about, I will teach you Castleman's. And it's the problem with Castleman's disease, it's really not a disease. It's a collection of many different diseases. And so, here's the problem with, so the crux of Castleman's and why it's horribly understood and many times oftenly mismanaged. It's the trifecta, or it's got everything, right? It's incredibly rare. Okay. So you don't see a lot of it. 2, it's actually many different diseases. And then 3, it falls across many different specialties. So no one specialty kind of takes ownership, although hematology, oncology kind of has. These patients can present to every different specialty, and they often see many different specialists before they arrive at a diagnosis. So it's the trifecta of a hard disease to grasp and treat appropriately. So first, I'm going to talk about Castleman's, the spectrum of Castleman's disease in a framework to approach this. First, what is Castleman's disease? So it's not a disease. So basically, what is in common with all these is there's lymphadenopathy, okay? And a lymph node is resected for whatever reason. Usually it's enlarged or the patient has other symptoms concerning for an infection or a lymphoma. And the pathologist looks under the microscope and they see findings, in their opinion, that could be seen in Castleman's disease. And you don't need to memorize these findings. This is for the pathologist, but there's a broad array of findings that could be seen in the lymph node, from an infiltration of polyclonal plasma cells to fibrosis and onion skinning to atretic or regressing germinal centers. So there's all these different things that can look like Castleman's disease. So the pathologist, if they're good, will look at under the microscope, say, this looks like it could be Castleman's disease. They rule out lymphomas, infections, fungal infections. And then it comes to the clinician to funnel into the appropriate actual diagnosis, which I'll now go over. When this disease was first described in the 1950s, it was in a group of patients that presented, a lot of them with mediastinal lymphadenopathy or masses or isolated cervical nodes. They were completely asymptomatic other than something found on imaging or a palpable lymph node. And they were referred for an excisional biopsy, and these patients were resected. And they came back with these findings, these constellations of findings in the lymph node that we just described about, that was given the names Castleman's disease. And if they imaged the rest of the patient or did a thorough examination, there was no other lymphadenopathy. And these patients are what we now know of as unicentric Castleman's disease. Basically, asymptomatic other than an isolated or a regional group of lymph nodes that are enlarged. And when you resect it, it's gone and the patient's done with the disease. They don't have any B symptoms, no inflammatory symptoms, no other lab abnormalities. They should not have any of those findings. If they do, then you need to think of a different disease, or they have a collection of 2 different diseases, okay?
So is it like a diagnosis of exclusion?
Basically, it has to present. So unicentric Castleman's disease, the pathologist has to have these Castleman's-like findings that they report, and they present with one lymph node. Usually it's in the mediastinum or the cervical or in the cervical chain. I've seen patients that presented with large intra-abdominal masses. I mean, I had a case where a father was donating his liver to his son, or part of his liver to his son, who was born with a congenital liver issue. And when they were staging him they were doing scans of his liver, they found a huge 10-centimeter intra-abdominal mass that they resected. The guy was asymptomatic. I mean, they resected it and it came back as Castleman's. And in today's era, most cases of unicentric Castleman's that I'm seeing are incidental findings on imaging, and they see this abnormally enlarged lymph node or mass, and they're concerned for a cancer, and they're resected, and it comes back with these findings, and then they come to me and they go, "What's wrong?" And I go, "Okay, well, this is clearly unicentric disease. It's one spot. They have no other symptoms. Their labs are fine. This was found by accident, or just they have a palpable lymph node, and that's what it is." And what causes this? We have no idea. Well, we're looking into it, and the suspicion is that there is not cancer, but a clonal population of cells within the lymph node, particularly within the follicular dendritic meshwork. So follicular dendritic cells, which I won't bore you to death on, have a mutation that secretes chemokines, cytokines that cause these abnormal lymph nodes or masses.
So is Castleman cancer?
No. Some maybe.
So why would you treat it? Why would you treat it then? Like we
haven't got to that yet. So we're treating. So unicentric, that's unicentric. I hope there's no confusion on unicentric. Okay.
Unicentric is
asymptomatic, other than the regional node. Yeah, I mean, you can have symptoms related to the mass of lymph node. It's compressing, but that's it. Okay.
Okay.
Now, the more confusing clinical scenario is the classic patient presents with fevers, B symptoms, maybe fluid retention, and they present to their PCP, and there's concern for an inflammatory disorder or a bad infection or even a malignancy. At that point, usually labs will be drawn that might show an inflammatory anemia, elevated immunoglobulins, a high ESR, CRP, and imaging studies done because they're scared about cancer, which I would be too. And on that imaging study, they see multi-station lymphadenopathy, usually fairly 2 to 3 centimeters, usually not like 20-centimeter nodes, so fairly modest lymphadenopathy. They're then referred for an excisional biopsy because the concern usually is lymphoma at this point. And the biopsy comes back with findings consistent with Castleman's disease. The pathologist does a good job. They don't see any Hodgkin's lymphoma, no follicular lymphoma. They stain for fungus. They look for all these other things, and it comes back as Castleman's finding, unless there is some other diagnosis that the clinician is entertaining, like a really bad autoimmune disease. So at this point, they come back to the clinician who has these lymph node findings. They have these inflammatory symptoms, lab abnormalities, and the clinician needs to exclude bad autoimmune disease or any other inflammatory condition that has been described that is not causing all this. And that can be done with appropriate blood work and clinical history taking. And at that time, you can say this patient has multicentric Castleman's disease, okay, after you've excluded that. Now, multicentric Castleman's disease, there's really 3 flavors. I'm going to go over the 2 most important flavors. One is HHV8, so human herpes virus 8, associated multicentric Castleman's disease, which is almost always found in the setting of a concurrent HIV or AIDS diagnosis. Not 100%, but close to 100%. So don't think of it as HIV multicentric Castleman's. It's really HHV8 multicentric Castleman's disease that just happens to most of the time occur in HIV. And if they're HHV8 negative, which is done by staining on the lymph node, they will do the LANA staining, okay? And if it's positive, that's what they got. And we'll talk about how to treat that. If it's negative and you've excluded everything else, then they have what's called idiopathic multicentric Castleman's disease, otherwise known as the David Feigenbaum disease that he himself had.
How often do you see idiopathic versus HHV8? What's the...
It's more now idiopathic than HIV. It used to be more HIV. Now with appropriate antiretrovirals and less advanced HIV, we're seeing more of the idiopathic. But I'm going to talk first about the HHV8. So when you have a diagnosis of multicentric Castleman's disease, or at least that's what you're thinking, the most important thing is to make sure it's HHV8 positive or negative, because they look clinically similar and they have similar pathologic findings, but they are managed in a really different diseases. So in
Right.
HHV8, Castleman's disease, multicentric Castleman's disease, these patients are sick. They usually have advanced HIV. Not always. They can be immunocompetent, but usually they're not. And they're usually in the hospital. And there's usually a concern at the time when they're admitted for an HIV-associated like DLBCL or Burkitt lymphoma, but the biopsy comes back with the surprise of HHV8 positive.
Do you just read the HIV and it goes away?
No, so usually not. So the Kaposi sarcoma virus, or excuse me, HHV8, that virus secretes high levels of, so it infects plasmablasts and lymphocytes, and then they secrete high levels of virally encoded IL-6. And that's what drives this process. So very high levels of viral IL-6 trigger enlarged lymph nodes, fluid retention, swelling, inflammatory symptoms. So the way you treat this disease is you need to get rid of that. You need to eradicate the HHVA. You need to, and the reservoir is in these B cells. So we have a very good B cell directed therapy called rituximab, and you give them rituximab, usually 4 weekly times 4. And you look at the latest data, you basically cure, and then you start them on antiretrovirals if they're not already on. Most of these patients go on to live a completely normal life, and you cure that. Okay, so it's treated similar to lymphoma because we use rituximab for B cell lymphomas. That's because the cell is infected. It's a B cell, but it's not neoplastic. Okay,
It just makes it, and that's why it made me wonder: do I need the Rituxan even? But it's hard to tell.
You do, and you can. And there's been studies with antivirals directed towards this virus, but in the Rituxan era, that's the way to go. And you give them that, you give them antiretrovirals, and then you they're done. Okay. Now, idiopathic looks very similarly clinically to the HIV, HHV8 positive, except they don't have HIV and they're HHV8 negative. Okay. So it's truly idiopathic. And we'll go into a little bit more detail on the disease, but what causes it? We don't know. Okay. There are a few hypotheses. One is that there is a small clone of neoplastic cells driving this, although it's been hard to prove. 2, maybe it's another infection or virus that we just don't know about or haven't been able to find. Or 3, it's some sort of auto-inflammatory condition, more like an autoimmune disease, but we really haven't been able to definitively prove that. My guess is it's probably all of them. Like, we group this all as one disease at this point, but as we get more sophisticated with our genomics, our testing, we might be able to separate out pies, slices of the pie from this diagnosis of IMCD. But what they all share in similarity is we don't know what's causing it. They have no other explanation. Mm-hmm. They have markedly high levels of IL-6, but this time it's not viral IL-6. It's your own IL-6. Something is driving you to make too much IL-6, and they have multi-stage lymphadenopathy, fluid retention, fevers. They can have lung infiltrates. They can have all sorts of symptoms. And once you funneled into that, the treatment, we have an antibody. There's actually 2, but there's one that's FDA approved, an antibody that's directed towards IL-6, and it binds the actual IL-6. It's called siltuximab. There's a similar drug called tocilizumab, which we now use all the time for cytokine release syndrome after CAR-T, which is driven by IL-6. That drug is slightly different. It binds the IL-6 receptor, while siltuximab binds the actual molecule. But there was a study, a randomized study in this rare disease. It was a randomized phase 2 study. Where they randomized patients with idiopathic multicentric Castleman's disease, meaning they didn't meet the criteria for anything else. We had no idea what was causing this. They had Castleman's findings, high IL-6, and they were randomized to siltuximab versus best supportive care, whatever the other doctor could basically come up with. And siltuximab, I won't get into the nitty gritty, it won. There were more responses.
But in multicentric idiopathic, there's no point of giving Rituxan or chemotherapy?
We'll get to that. So the standard of care, and we've written now guidelines. There's a working group really spearheaded by Dave Fagenbaum. I sit on it, where we wrote very detailed guidelines for IMCD. It's published in Blood. I think it's already a few years old. And the first line treatment. So when you see someone with MCD, you first need to, and it's idiopathic. So first, make sure your diagnosis is right. Okay, that's the hardest part. And then the next part is, do they have severe or not severe? And there's specific criteria for severe, but to make things simple, severe, they're in the hospital, they're sick. Okay, they're not walking into your clinic. They're sometimes even in the ICU. And the initial treatment, actually for severe and not severe, is siltuximab. Okay, so that is our recommended first-line treatment. And in about 50 to 60% of patients, they will respond. Okay, and in my experience and in the literature, if you respond, you seem to respond nearly forever. Just about everyone continues to respond. And the response in the disease, the problem is we're lymphoma doctors and we're trained to think like lymphoma doctors. Actually, usually their lymph nodes don't shrink that much. They shrink some, right? We're not really attacking the lymph nodes. We're just mopping up the IL-6, which is driving the abnormal symptoms and signs in the patient. And so usually the lymph nodes don't get much smaller, but you know what does get better? The patient feels like immediately better, sometimes within hours of the doses. Fevers
Wow.
over the course of weeks to months, their lab abnormalities regress, and depending on how critically ill they were, determines the duration of recovery. But if they're in that responding group, in my hands and in the literature, they just about respond forever. And when I say forever, we've only been giving this drug for, I don't know, 7 or 8 years. But that seems to be the case. And the drug is I sound like a pharma rep, but I mean, it's really an easy drug to give. It's a monoclonal. It's not chemo. You give it every 3 weeks. It's not really immunosuppressive at all. There was no increased risk of COVID when they discussed it. Actually, most patients, their cholesterol and they gain weight because they feel better and start eating again.
No, it's
And
target against
yeah,
what? Monoclonal?
IL-6, IL-6.
IL-6. IL-6.
Yeah. And in my hands and in some of the data, you can start spacing it out as they get much better. Now, who's going to respond? Typically, those who present with really high ESRs, polyclonal hypergammaglobulinemia, those are the predictors of response, but we still recommend giving it to everyone with idiopathic. The problem is half of the patients won't respond, okay? And typically, in that half of patients who don't respond, it's enriched for a subtype of idiopathic multicentric Castleman's disease. So IMCD, there's a flavor of it called TAFRO, and TAFRO stands for thrombocytosis, anasarca, reticulin fibrosis, and organomegaly. It just rolls off the tongue. And unlike IMCD, the regular type, instead of seeing thrombocytopenia, you see thrombocytosis, you'll see organomegaly, you'll see almost the bone marrow looks like myelofibrosis and is very fibrotic. We see this variant more common in Japan and Asian populations. For whatever reason, we call it IMCD, but probably a different disease. They don't seem to respond as well to IL-6 directed therapy. Some of them will, but sometimes they don't. And there we don't really know how to treat them. And so we treat them kind of like a lymphoma. And if they're really sick, the recommendations are multi-agent chemotherapy. Some doctors like myself favor more like R-CHOP or RCVP, but the Arkansas School of Thought is to treat them more like a myeloma because we're like VDT pace, those types of regimens. But we really don't know the optimal treatment. And in some of those patients, you'll get them into remission. And what to do after, we'll sometimes give them a few more doses of rituximab, and hopefully they have a durable remission. And Dave Feigenbaum, he'll talk about his case all the time, but he would get into remission with each round of these intensive chemotherapies for X amount of years and then relapse. And so the field's desperately looking for alternative therapies in those who are not sensitive to siltuximab, where chemo and rituximab, either you can't keep on giving it because of toxicity or it doesn't work. And there's some data with mTOR inhibitors and things like that, okay? And I'm going to keep going on. I want to talk about one other thing. There's one other type of Castleman's disease.
I
And
don't
then
have a choice. You're going to
yeah,
keep going on.
yeah, and then I'm going to summarize it all for you in a neat minute to make it make sense. So there is the final variant of multicentric Castleman's disease. So we've talked about HHV8 associated Castleman's multicentric in the setting of HIV. We've now talked about idiopathic MCD, which comes in the regular type and then that flavor called TAFRO that presents a little bit differently. Usually patients are more sick. And then the final type is POEMS associated multicentric Castleman's disease. See, all rare, all called Castleman's, but all really different beasts. POEMS associated Castleman's disease is truly a bona fide neoplastic process, okay? This is due to a clone of plasma cells. We know this. And these patients they don't have myeloma, they present with this constellation of symptoms of polyneuropathy, P, organomegaly, endocrinopathy. They all have an M spike. They have to by definition. It's usually an IgA lambda, although it can be other flavors. And then they have skin changes. And they have this horrible neuropathy that's sensory motor. So the predominant symptom is that usually they present with a predominant sensory motor neuropathy that's quite debilitating. And they have a monoclonal protein. Unlike myeloma, if you image them, you won't see lytic bone disease. You'll see sclerotic bone disease, and you'll see lymphadenopathy. And if you biopsy those lymph nodes, you'll see Castleman's findings. I'm going to tell you right now, don't think of this disease as Castleman's disease. Think of this on the spectrum of plasma cell dyscrasis. Most of the time, I don't even biopsy the lymph node. I don't care that it has that. That usually results in confusion. The Castleman's findings in the lymph node is a symptom of the monoclonal plasma cells. And actually, if you look, they have elevated IL-6 levels and VEGF levels. So it's just a symptom. Just like Castleman's findings in HHV8, it's a symptom of the HHV8. In idiopathic, it's a symptom, but we don't know the cause. And for POEMS Castleman's disease, you treat with plasma cell-directed therapy. We tend to, so everything we use in myeloma, we tend to avoid Velcade and bortezomib because they already have neuropathy and that makes it worse. So IMiDs, daratumumab. There used to be a push for transplant. Actually, in the era of daratumumab,
I was going to ask about transplant.
just like an amyloid, we used to transplant them all. With POEMS, it's not a clonal problem. It's usually a small burden of clonal cells, unlike myeloma, where you have a high burden of clonal plasma cells where you need transplant and aggressive therapies. Just like amyloid, you can get away with less aggressive therapies, wipe out that clone, and result in a very durable remission. Now, we don't have as robust data, but I suspect in the era of DARA, if you can wipe out that clone, get it to a minimal level, I see no role of consolidating with a transplant. Although I will say, if you transplant someone with POEMS, they can have a mega long remission because, right, the clone, the burden is very low. So these are very rare patients. The point of POEMS is if you see POEMS, your differential should be, so what's your differential for clonal plasma cells in neuropathy? So my differential is amyloidosis, POEMS syndrome, and then IgM associated with anti-MAG antibodies, peripheral neuropathy. So
myeloma. Myeloma could cause that.
In myeloma. And again, so unfortunately, if you biopsy the node, there's Castleman's findings and it gets lumped into Castleman's disease, but it's really a completely different thing. And I don't even think about it as Castleman's disease. So to summarize.
Yes, this is the fastest Castleman disease crash course that we have gotten. And it's basically helped with consumption of beer. So let's summarize this in 1 or 2 minutes.
In 1 or 2 minutes, basically, they all have lymphadenopathy. And the first thing, if it's in one spot, these patients are predominantly asymptomatic. They are, by definition, no lab abnormalities. You cut out the lymph node. The pathologist goes, this has Castleman's findings. They send that back to you. You look at it. You scan them everywhere. They have no other lymph nodes. They feel fine. That is a diagnosis of unicentric Castleman's disease. Clinical management afterwards, nothing. Although if you look at the NCCN, which for the record, I disagree with, there's recommendations for like annual scans and all this crap. I don't do any of that. I'll see them once a year just to say hi. Okay. The other group is multicentric Castleman's disease, where they present with multiple lymph nodes, modest in size, in inflammatory symptoms, B symptoms, weight gain, cytopenias, and you biopsy the lymph node. It has Castleman's findings. You need to make sure it's not HHV8 positive, which you do with staining. If it is, they almost always have HIV. You treat with rituximab, control their HIV. If they're negative for HHV8, then they have idiopathic MCD. You've ruled out everything else. Then the answer is IL-6 directed therapy with siltuximab. If that does not work, then you start looking at rituximab and chemotherapy. And then there's
amazing.
POEMS associated, which we just said, think of as a plasma cell.
In the 40 to 50%, my last question, I'll let you go. I know we have a hard stop. And my last question is, in the 40% of patients or 50% who don't respond to siltuximab and still you give chemotherapy and this still doesn't work, maybe less than 40%. This is where the unmet need, where there are some investigational therapies and trials. I mean, how many Castleman's disease cases are we talking about a year in the US? I mean, how prevalent is this?
So if you lump them all together, it's a few thousand or so.
Okay. So it's not easy to, it's like a rare disease, an orphan disease kind of thing.
It's an orphan disease. So Dave Feigenbaum, I encourage anyone with a Castleman's disease, there's what's called the Accelerate Registry, which you just tell them to log on to, or you can do it for them, which is a database made by Feigenbaum. And then their team will literally reach out to the patient. And this is how we're collecting all this longitudinal data. But I tried to open it at UCSD. There's some issues, but at Penn, Feigenbaum has a study for relapsed Castleman's looking at mTOR inhibition with sirolimus, which is...
Well, he has done great on it. I mean,
so we encourage patients to do it. I will say it's hard to get patients. Not everyone can move to Penn. So what I'm doing for my relapsed refractory patients, I have done off-label that drug with some success. There's also data with, IMiDs. In China, they use a lot of IMiDs, thalidomide, Cytoxan, even Velcade. They treat it like myeloma. But you're right. I mean, right, it's amazing that we even have a clinical study in the disease.
Okay.
But if you reach out to their team, they're usually very helpful, and they can provide with advice or hook you up if you don't see a lot of this with the most nearest Castleman's guru. And I always feel like a fraud. Like, I saw a few of these a fellow, and I was the guy at UCSD who now sees them all. And like, I don't consider myself an expert, but I guess if you see, a few of these a year, you are an
Listen,
expert.
if you're seeing
Yeah.
a few of these a year and you
Yeah.
know how to treat them, you're an expert.
Yeah.
Aaron, thank you so much for spending some time on the HemOnc Pulse. This was great. Quick update on Castleman's disease, next steps. And I know that you have hard stop, and I promised you I'll get you out very soon. So here I am, fulfilling my promise.
Yeah, perfect. Yeah, I don't want to anger the wife. That's important.
Never anger the wife. Aaron Goodman on the HemOnc Pulse. Thank you so much for coming on.
Thank you.